I brought two cases for you. One case is a case of a 42-year-old female patient who died due to sudden cardiac death during sexual intercourse. She was successfully reanimated by the husband. In her medical history, she had only palpitations and some exercise-induced chest oppressions, but no other cardiovascular comorbidity were known. With physical examination, pulsus bisferiens can be observed. On the ECG, we just saw sinus tachycardia, but otherwise it was normal. By auscultation, a 4 to 6 hollow systolic murmur at the apex was heard, a harsh ejection type systolic murmur at left sternal border, which increased with exercise, and the lab tests were normal. This was her first two-dimensional parasternal long axis view, and using the transthoracic 2D parasternal long axis image, already several pathologies could be observed. First, there was an elongated and thickened anterior mitral leaflet. Second, the posterior leaflet was also thickened and prolapsed above the annular plane. And the most striking observation was those weird, extremely redundant anterior cords folding over on themselves and appearing as swirling patterns. The left ventricle seemed to be normal in systolic function, but it was hypertrophied and dilated. This was the apical four-chamber view. The mitral valve apparatus resembled a pier. The narrower apex of the pier was formed by the redundant anterior cords. In diastole, the redundant chordae started to buckle and fold up on themselves, giving rise to a word pattern. So it was quite a strange view. We started 3D with X-plane, and with X-plane imaging, a giant papillary muscle was depicted with extensive calcification in its head. You can see it on the right side of the X-plane, and the redundant chordae had a mesh-like appearance. On the apical long axis view, it was clearly visible that the loops of the elongated chordae prolapsed into the left ventricular outflow tract. We put, of course, some color on. This was an off-axis image, and color Doppler revealed a large mitral regurgitant jet in the left atrium and another oblique turbulent jet below the anterior mitral leaflet in the left ventricle. From this off-axis view, it was not possible to exactly define the direction of the regurgitant jet, but we mainly observed two different jets toward the left atrial anterior wall and the central part. So we needed some slight angulation of the probe, and we found this second eccentric jet directed toward the anterior wall. So, what is the diagnosis? Any idea from the audience? Or we can go further. You need further information. Any idea? Les, please. I'm sorry, I can't hear you. We will, but in that case, it's too easy. Okay, let's go further. So the left ventricle was on the upper limit of the normal range, ejection fraction maintained. There were no wall motion abnormalities. Right function was good. TAPSA was 24. Dilated left atrium. Mitral inflow was normal, but there was a grade 3 mitral regurg. And the striking finding was that there was a dynamic outflow tract obstruction with a severe gradient in the left ventricle. It was not easy to differentiate between the anteriorly directed mitral regurgitant jet and the gradient in the left ventricle. They were so close to each other. So this is the short axis view. I'm going to show you what you wanted. It was technically difficult to acquire good paracernal short axis view because of the translational movement of the heart in the chest, and the papillary muscles were difficult to identify. But real life images. But with careful and meticulous inspection, only one papillary muscle could be observed. That was located on the posterior-medial wall of the left ventricle. In the location of the anterolateral papillary muscles, only trabeculae could be seen. So the two-dimensional images raised the suspicion of a parachute mitral valve, and we acquired performed TOE and acquired 3D TOE loops, of course, in order to assess the papillary muscles and the mitral valve. The three-dimensional echocardiography is very helpful for locating papillary muscles. So we cropped the data set, and it clearly showed that all the chordae tendinae were inserted into a solitary papillary muscle group, which is consistent with pseudo-parachute mitral valve. In case of a pseudo-parachute mitral valve, the mitral apparatus is also distorted. The mitral leaflet might exhibit rheumatic or myxomatosis traits. So let's go further. We made the multiplanar reconstruction from the full volume loops. And in our case, the papillary muscle group consisted of two muscles located onto the posterior wall very close to each other. One papillary muscle had a medial superior attachment, as you can see, and the second papillary muscle had a little bit lateral and inferior insertion on the wall. In contrast to childhood parachute mitral valve, when marked shortening and thickening of the chordae cause a funnel-shaped severe stenosis of the mitral valve in the majority of the cases, in the adult parachute mitral valve, it is extremely rare in the clinical practice, and is the stenosis mild or there is no stenosis at all. Our case showed a very marked anterior chordal redundancy with the chords almost folding up to double, and that resulted in severe dynamic ventricular obstruction, intraventricular obstruction. So we also used, of course, color full volume and explain images. And the dynamic subvalvular obstruction resulted in flow acceleration, which pushed up both the anterior and the posterior leaflets and caused some prolapse of the mitral leaflet. And the location of the subvalvular obstruction was different from the form that we might expect in, for example, hypertrophic cardiomyopathy. But it was severe. Mitral regurgitation was quantified as severe by the vena contracta area measurement, which was 0.4 square centimeters. And we also produced the model of the valve with mitral valve navigator, and the prolapse of the lateral scallops and the pseudocleft between P2, P3 indicated leaflet tissue abnormality. So this was the final transesophageal report. One papillary muscle group on the postero-medial LV wall, elongated calcified chordae originating from one papillary muscle causing dynamic obstruction at 2 locations in the LV, subsequent A2, A1, P1 prolapse, a pseudocleft between P2, P3 with severe mitral regurgitation, normal aortic valve, but a significant dynamic subvalvular gradient. What was the clinical course? Pseudo-parachute mitral valve with severe hemodynamic consequences should be operated. In our case, probably the dynamic LV obstruction caused malignant arrhythmia, and it was the main reason for the sudden cardiac death. The therapy was surgical valve replacement. You cannot repair those valves because the subvalvular apparatus is so much abnormal. And after uneventful post-surgical period, we follow the patient, and she is still asymptomatic during the 2 years follow-up. What to know about the parachute mitral valve? This is a rare congenital anomaly in the adults, predominantly in males. It is isolated in 50% of the cases, but it might be associated with bicuspid aortic valve or coarctation. There is only one papillary muscle or one papillary muscle group. The chordae might be either dysplastic and result in mitral stenosis, or elongated and redundant, as in our case, and cause subvalvular obstruction. The parachute mitral valve might be part of the Schoen complex, which consists of stenosis on different levels, supravalvular mitral ring, parachute mitral valve, subaortic stenosis, and coarctation in the thoracic aorta. Thank you for your attention.
Thank you for this very unusual case presentation. Are there any questions in the audience? If not, thank you very much. We'll go to the next case.
Okay, please, would you so kind to help me to close and open the second case?
Astrid Apor.
So I have another case from the near past. It was a case of a 49-year-old female patient. She was referred to our hospital for severe pulmonary arterial hypertension and fever. Our patient was previously considered a healthy adult female. She had delivered 2 children, and the complete medical examination required at time had been judged to be normal. About 1 month before her admission, he presented in a local hospital with pyrexia and malaise. She was given medication through the right cubital vein, where a local infection developed, and that was treated. 4 weeks later, she was rehospitalized due to palpitations, fatigue, and fever, which persisted despite antibiotics. On physical examination, we heard the systolic murmur over the left precordium, and with pulmonary auscultation was nothing abnormal. ECG showed the sinus tachycardia with right bundle branch block, and the lab test showed biomarkers elevation regarding infection and anemia. The transthoracic examination was technically difficult, but we saw normal cardiac chambers, normal valves, severe, and a young colleague reported as there is a severe tricuspid regurgitation, and the calculated pulmonary systolic pressure was extremely elevated in accordance with the previous result. So we went further. We still didn't have, no, I'm sorry, it was too quick. I would like to get back, just a moment. So we went and performed a transesophageal echocardiography. Can we make it run the loop, please? Okay. We immediately performed this TOE, and it demonstrated a large irregular shaped oscillating and highly mobile mass in the right atrium, located above the tricuspid valve septal leaflet. Its attachment was not precisely seen, but the mass didn't cause any obstruction at the level of the tricuspid valve. The echo representation of the mass was characteristic of large vegetation. Oh yeah, here you could see the mobile mass looking like vegetation. With color Doppler, we detected a high velocity oblique jet in the right atrium, which raised the suspicion of a communication or a defect between the left heart and the right atrium. This suspicion was based on the unusual direction of the jet and its high peak velocity, which exceeded 4.5 meters per second. And it reflected, this high velocity reflected high pressure gradient between the origin of the jet and the right atrium. So we continued with explain. On first inspection, the aortic root and the aortic valve itself didn't show any abnormality. And then we acquired 3D loops in order to define the exact attachment point of the mass and the origin of the weird jet in the right atrium. Live 3D, full volume, and 3D zoom data sets were acquired on the region of interest. With some difficulties, the right atrium and the mass and some part of the aortic root could be encompassed into the 3D zoom data set. Of course, frame rate dropped down, but it didn't disturb the further analysis with cropping and slicing. So let me show you the further analysis with slicing, with multiplanar reconstruction that always enables the accurate assessment of the spatial relationships in the volume data set. During this analysis with slicing, the blue and the green transaction cut planes were aligned with the axis of the left ventricular outflow tract. Therefore, the orthogonal fixed red cut plane, I just want to show you. I can't move there. So the red cut plane over there displayed the short axis image of the aortic root. Sliding up and down the red cut plane, we could exactly define the attachment point of the mass in the right atrium that was at the level of the perimembranous ventricular septum, close to the virtual basal ring of the aortic valve. Cropping the volume data set, we further analyze the region. This is the half-cropped data set. And with rotation of the data set, we could visualize the hole in the perimembranosus septum from the left side, and with rotating the data set from the right side. So there was a tiny hole, a small perforation in the membranosus septum just at the base of the vegetation. Careful review of the loops confirmed that a high-velocity jet crossed the ventricular septum through a small defect, forming a left ventricular right atrium shunt, which is consistent with Gerbaud defect. So this is the vegetation, the hole at the base, the aortic root caudally, and the shunt between the LVOT and right atrium and the tricuspid valves. This defect was the cause of high-velocity jet in the right atrium, simulating pulmonary arterial hypertension, probably due to the summation of the tricuspid regurg and the Gerbaud defect. Our patient first echocardiogram, I'm sorry, I get back. Our first patient echocardiogram was initially probably misinterpreted as severe pulmonary hypertension, and it's very common in case of Gerbaud defect. After 3 weeks of treatment without fever, she underwent surgery. Through a right atriotomy, large vegetation in the right atrium was removed, and the defect represented an acquired Gerbaud defect and was closed by plagiated pericardial autolog and running suture. The septal leaflet of the tricuspid valve was resected, and the entire tricuspid valve was repaired. The postoperative period was uneventful. So what to know about the Gerbaud defect? It's a rare form of the ventricular septal defect, which causes a shunt between the left ventricle and the right atrium. It might be congenital or acquired, and if it is acquired, it is a consequence of or complication of infective endocarditis. The membranosus septum, inferior or superior of the tricuspid valve, can be affected, and it very often might be misdiagnosed as pulmonary hypertension. Normal pulmonary diastolic pressure using the pulmonary regurgitant jet may help in differential diagnosis. Thank you for your attention.